So I'm excited to be here. Thank you all for the pleasure of the podium today. So I've got a slightly different twist on mine, and that is the perspective of what are our future technologies looking like and how can they help us? So in full disclosure, I do consulting work for Intuitive that will not impact this in any way. So the first point that I want to start with is one that I think is important to everybody in the room, whether you do surgical interventions, IR, or GI procedures, and that is that no technology is ever going to cover bad technique. So the first thing that I want to start with here is that if you continue to maintain all of the concepts that you have heard through multiple other courses, for example, our safe cholecystectomy thing, that's going to get you the best outcomes. I think why this made it to the podium, however, is because we want a place to discuss our technologies and what our data is showing us as these new technologies come onto the market and as we start to incorporate them. I think what we would all like to see is the additional benefits of the improved visualization, views that help when you hit challenging situations, whether that's anatomic or variation related to the edema of an acute gallbladder case, and things like wrists that could potentially help with exposure. The beautiful robotic endoscopy being the exact same thing to me as being the robotic laparoscopic equivalent. Things like that I think are going to open the doors for us in future things that we can do. And I will again kind of throw out the disclosure that sometimes the data runs behind what expert opinion is, but I think it is very important that we do prove to ourselves why we are doing things and what our pros and cons are in certain scenarios. So I feel like this is fun for the SAGES audience in terms of the death of laparoscopy. So they basically took the progressive models looking at these future predictions on where cases are going from what they've done over the past number of years. And in many procedures, including a number of general surgery procedures, this is showing a decrease in definitely our open rate, which I think everybody in this room would support, but potentially also a decrease in our laparoscopic rate as we get a rise in the robotic approach to surgical intervention. So looking at robotics and ICG, I figured I would go back and forth today between the personal experiences and what the published papers show, because I hope this talk will motivate everyone in the room who is doing this to keep all of your personal experience like I can show you today and take that to the next level of getting it out there so we've got the data that we need to support these things. So this was a gallbladder that I did. On the left, I would not have told you that there was anything odd or strange, but obviously when I switched over to the ICG cholangiogram portion, I could see this beautiful ductive Luschka with a small extravasation and was able to address that before I finished that case. Did that help that patient? I'm not sure. It made me sleep at night a lot better, but did I actually change the ductive Luschka rate? Would this have been a clinically significant bile leak? I don't know. So when we look at the consensus guidelines, there's some good information out there with regards to identification of anatomy with the ICG fluorescence imaging. And again, it kind of goes back to the concept that many of us think that we are very good at identifying anatomy, but the most common reason for a bile duct injury is misidentification of abnormal anatomy. So as we add the ICG to our armamentarium, as we add this additional tool, what we see are that most surgeons are able to clearly identify the cystic duct and the cystic gallbladder junction. But anytime we're looking at things beyond those two areas, we are less ideal without having that extra set of eyes. The addition of the ICG helps us see what we think we are seeing in the first place. All of those being statistical differences as we use that as a tool. I find this super helpful in cases that are disasters. If anyone would like to come do these cases, I'd love to bring you to University of Tennessee because I'd like to do the ones that take about 10 minutes and don't look like this. But having that line of demarcation, for example, to show me where the dead, rotten acute coli meets the liver bed really helped me on this case. Again, this is an N of 1. It's been repeated multiple times, but for the sake of the video today, it's an N of 1. But does that really help my outcomes as a surgeon? I would tell you that I believe it to be true, but do we have the data to show? So in terms of data that's been published, we've got information that says that our high-risk gallbladders, right, the ones that you don't necessarily expect to be challenging, the elderly patient, the male population, and the pre-op diagnosis of acute cholecystitis, which are our risk factors that we've identified in multiple previous meta-analyses. Those are our things that we worry that will increase our risk for conversion to open. So this was based on robotic cholecystectomy with the use of the ICG fluorescence, and it showed that in each subpopulation you had a decreased risk for conversion to open. I'm not exactly sure how to interpret this data because I think a lot of people, particularly that are younger than my generation, where you didn't train on the robot when you were in residency, but you did train laparoscopic, we don't do open gallbladders to the extent that many of the people who are older than my generation did prior. I don't think we're as comfortable open. And I think as long as we have options and tools in our toolbox that allow us to be safe while going forward, I can't say the correct answer is not to convert to open, but if you don't know how to do it open, maybe the correct answer is not to convert to open if that's what you are not as comfortable doing. But again, having that tool in the toolbox definitely decreases the risk of the conversion rate and allows you to complete the surgery. This is a study of greater than 3 million patients, and I think this goes to the predisposition of people selecting robotics versus laparoscopic. You know, when you hear people who are starting on robotics, they're like, oh, but I can do all of these easy cases on the laparoscopic system. I don't need the robot available in those cases. So on this retrospective study, you definitely saw an increased risk in the robotic cholecystectomy population for complications. But when you look at your patient preoperative population, these aren't equivalent anymore, right? You're doing the hard cases on the robot and wondering why the outcomes of the hard cases are not as good as the outcomes on the easy cases. So it's not great data because we're not really comparing apples to apples. We're comparing apples and oranges and wondering why we're getting a fruit salad with data that we don't really know how to interpret. I do think this one is a good study because it talks about specifically in laparoscopic, so again, taking the robotic piece out, that again, the fluorescence cholangiography can help you with reduced operative room time, conversions to open. I'm not so sure about the estimated blood loss difference of 10 mLs. I feel like most of our surgical colleagues are probably not accurate to our blood loss to the level of 10 mLs, but I will say that that was a statistical difference in Santiago's paper here, and need for drain placement. What I do like about this, though, is that this is one of the arguments that I think he did well with this paper, is that he looked at the difference between the inflamed and the non-inflamed gallbladder. So even in the non-inflamed elective outpatient scheduled case, there's still a 30 minutes difference in the operative time by having that additional view. Having that additional anatomy identification up front allows you to proceed because you know when you can go and when you need to be safe and slow down. So I think that's an important thing to think about in this setting. I think this is another interesting one. So everybody in the room probably knows that when the world of laparoscopic cholecystectomy came out in 1984, there was never a randomized controlled trial that we looked at showing that the increased rate of common bile duct injury for the laparoscopic approach as compared to the open made that worth it, because all of these benefits of going laparoscopic from open provided outpatient ability, shorter hospital stay, decreased hernia risks, all of those good things, and that just became our gold standard of care without that. I think this is an interesting group because, again, looking at this first paper, and again, I've got a second paper here that'll contradict this data, the increased risk for bile duct injury is present. It's a 0.4 versus 0.2. That did reach statistical significance in relative risk for this study population, but was also one of those things that we look at the similar thing between open and laparoscopic, and we accepted that 0.2 difference versus, 0.3 versus 0.1, but total complications, serious complications, all equal in this study. The other question becomes is, are we converting our laparoscopic population over to robotics, or, as mentioned in the previous study of the retrospective 3 million patients earlier, are we now expanding our ability to keep our complicated patients in a minimally invasive technique? When I do a BMI of 83 on the robot, I can do a minimally invasive technique. When I'm trying to do that laparoscopically, pardon me for sounding difficult, I can't stand at the end of a laparoscopic instrument and bounce up and down against that belly wall and have any level of success. I just can't do it. So it may be such that we're introducing a new population into our group that we can now apply our minimally invasive techniques in. And I think, again, looking at that and making sure that we're understanding what our benefits are from these technologies as they come out is a very important thing. So this is an example of one of the patients that I took care of. I did the straightforward gallbladder, and then I'm looking at the liver bed, looking for my ductal Vlushka, and I'm seeing this pooling of my ICG contrast. What that allowed me to do, again, was to investigate that further. I don't see bile clearly leaking anywhere. I don't see anything that's an obvious problem, but yet I've got a pool of ICG fluid that is not supposed to be there in my mind. So at this point in time, it let me investigate. I'm going to pass out the clip, and I'm going to come in with a sponge, and I'm going to clean up that area, and I'm going to spend some time looking around. And again, this is not the N of 1 that you always hear about in great 3 million patient studies, but I do think this imaging modality as a tool in the toolkit probably saved this patient a drain in the future and probably a trip back for an ERCP by this recognition intraoperatively. And I think if it's one of those things, sort of like the cholangiogram that we were discussing earlier, if you don't look, you don't know. Maybe these common duct stones are there in the 0.2% of completely asymptomatic patients, but if you don't do the cholangiogram in time in the operating room, you will see that to know that you need to intervene. So what I've done here is cleaned up the area. That way I can get a better view rather than trying to work in that pool of fluid. And on the backside of my cystic duct stump, you're going to see a small little side branch that's left a micro hole down below my bottom clip. So it's about much smaller than a millimeter in size because my robotic instruments are 8 millimeters, obviously. But you can see this tiny opening right there just below the clip where I've got an extravasation of bile coming from my cystic duct stump. So I placed a clip below that. The leaking stopped. I sat there and poked it about 15 more times because that's what surgeons do just to make sure that it, really had stopped. And that was taken care of. So I think that, again, technology probably showed this patient a very dramatic difference in the outcome. But I need more information to get it into that 3 million patient population to show everybody that that is really what happened, not just my N of 1 expert opinion. So this is the best data that we've got out there right now in terms of multi-study review, and it shows that the biliary injuries are even, despite the paper that I showed you a few minutes ago showing a slightly increased risk for that. It shows that robotic cholecystectomy has lower conversion rates, and it shows that the complications are even. So in summary, I would say we are still missing some of the data. I would urge everybody in the room as you investigate your new technologies, whether that is in this case ICG and robotics, or whether that is a different technology 5 years from now that we haven't even had on our radar screen, that you collect your data, that you work on being able to show the pros and cons of the things that you're using, and that we all communicate that information to each other so that we use the right technologies in the right places. Because I think fundamentally we all agree that beautiful vessel is very important to keep, and I need the visualization to help me find it. But what's the best thing for the individual patient, and how do we prove the cost effectiveness of that on our systems? So happy to do more questions.
That was a great talk. So unfortunately, we're